Good afternoon, everyone. Welcome to Dutch's Webinar Wednesday. Our webinar today is Men's Health and the Dutch Test. My name is Amy Paoletti, and I'm a member of the Dutch Education and Marketing team, and I'd like to thank everyone for joining us and taking time this afternoon. For anyone who's listening who might not have an account with us but would like to, please contact our team or go to our website and complete the Become a Provider form. We have an awesome opening order offer for all new providers, receiving up to 50% off on test kits, up to 5 test kits. It's a great offer, great way to get started with Dutch. Wanted to go over a couple housekeeping items before Dr. Jones starts today. We will answer as many questions as we can at the end of the webinar. You can send your questions in the questions section on the side panel of your screen. If you miss anything, please don't worry. We will be sending the on-demand recording tomorrow, along with the presentation slides. The Dutch test provides an excellent information for men looking to optimize their health and well-being. While it is common to focus only on increasing testosterone, other hormones play key roles in symptoms such as fatigue, abdominal weight gain, male pattern baldness, depression, insomnia, and much more. Testosterone and its metabolites and estrogen metabolism are all reported on the Dutch test. Dr. Jones will share and identify key sex hormone patterns from the Dutch test for men, differentiate phase 1 and 2 estrogen metabolism, and the importance in men's health, also evaluating 5A reductase and its effects on androgens and much more. Many of you who are online with us today are very familiar with Dr. Jones, but just in case you're not, Dr. Jones is the medical director for Precision Analytical. She is also a naturopathic doctor whose passion and expertise lies in the areas of hormonal, adrenal, and thyroid health. Dr. Jones graduated from the National University of Natural Medicine here in Portland, Oregon, and went on to complete her residency in women's health, endocrinology, and hormones. She later graduated from Grand Canyon University with a master's in public health. So please welcome Dr. Jones with us this afternoon.
Thank you so much, Amy. I appreciate it. All right, everyone. We'll go back to the title slide and let's jump in. As Amy said, we're going to go over men's health and the Dutch test. Basically, what I have done is for those of you that work with men in regards to their cortisol and their hormones, as I've broken apart the Dutch test to kind of go over like key enzymes and key areas that can really help you when you're personalizing their treatment plans. So quick, just a few slides about Dutch if you are new to Dutch. This is a diagram of basically everything that we test. And right in the center is the easy collection. We are very proud of that. And we are very proud at the comprehensiveness of everything that we offer for all of our practitioners. We know that you have a lot of options. And so when you're looking at dried urine, when you're looking at Dutch, and again, for those of you who are new, Dutch is an acronym, Dried Urine Test for Comprehensive Hormones. Because of the dried urine aspect of it, we are able to collect not only the hormones themselves, but also the metabolites, such as estrogen metabolism, androgen metabolism, cortisol metabolites. We do have the additional salivettes, the salivary part for the cortisol awakening response as well. You're limited when you do serum and you're limited when you do saliva. This was the premise behind Dutch, was to be the most comprehensive, easy to collect test and give you that big long list of hormone information so that you can apply it to your men. Dried urine looks like this. This is our filter paper. This is what you will collect as part of the Dutch Complete and the Dutch Plus. Simply urinate on them throughout the day, let them dry, and mail back to the lab. In addition, if you're doing the Dutch Plus, adding in the cortisol awakening response or doing the cortisol awakening response by itself, you have two options for test companies. You can do a salivette swab or saliva tubes. The swabs, of course, they're basically cotton swabs that you pop into your mouth. And because it's just a cotton swab that you pop in your mouth, you can get a rapid collection, a truer CAR result, and you don't have that spitting or passive drool. It's very helpful for those patients of yours who experience dry mouth. When they are doing cortisol awakening response research, they are looking at the swabs as opposed to the passive drool. The problem with the passive drool, of course, is generally time. People take a lot of time to fill up those tubes, and that can be a problem, as well as in some instances, you're advised to rinse out your mouth with water prior to the collection. And unfortunately, in some cases, depending on the person, depending on the patient doing it, is that might cause some dilution. So with Dutch, we have made the collection quite easy. We've opted to go with the Salivette swabs for our Dutch Plus, and of course our cortisol awakening response only. Many of you have asked, is there research regarding dried urine? And there is. In 2019, BMC Chemistry published this that looked at dried urine estradiol and dried urine progesterone, comparing it to serum estradiol and serum progesterone. And the results were quite similar in that you can see the top box is progesterone, the bottom box is estradiol, and you're looking at dry urine and at serum, and it correlates really, really well when done on GCM-SMS, which is mass spec. This is not immunoassay. Now, what's coming, pending publication, are when we look at dried urine compared to salivary cortisol results. Many of you have asked, well, is dried urine as appropriate as when I do salivary cortisol testing? Not with the cortisol awakening response, but for a general circadian rhythm when you do in the morning, a couple hours later, around dinner and before bed. Yes, again, this is pending publication. There is statistical equivalence between the rise and fall in saliva and the rise and fall in urine for free cortisol throughout the day. Now, you may be asking, well, they don't line up. They look similar, but why is saliva behind urine? Please remember, on urine, there is a time delay. The waking cortisol of urine is that's cortisol made through the night, run through the kidney, and put into the bladder. So there is a little bit of a delay. And then the 2 hours after waking, when you collect the Dutch test, that's actually all the cortisol that has been made, used, and put in the bladder from waking into that 2 hours later. So there is about a little shift in the awakening response there of 2 hours. So be on the lookout for this. Choosing the right test, how do you know? Well, we are going to talk about the complete and the plus today in regards to men's health. The complete are with all urine all the time. It's 4 urine collections throughout the day. We do offer a 5th overnight collection for those men who have insomnia. They wake up in the middle of the night. This looks at sex hormones plus the metabolites, cortisol, cortisone, and cortisol metabolites, and of course the up and down diurnal pattern. In addition, we added melatonin, the DNA damage marker 8-OHDG, nutritional and neurotransmitter metabolites, such as HVA, VMA, and MMA for B12. Dutch Plus is where we look at those same 4 dried urine samples, but we add in the 5 salivary swabs. The 5 salivary swabs are to give you the cortisol awakening response, plus add in the rest of the pattern throughout the day, where you look at it at night, around dinner and before bed. In this, we do not exclude our men with insomnia. We do include an extra overnight sample. So you are able to get the cortisol awakening response, get all the urine metabolites, and still understand why they wake up in the middle of the night. So the plus, when people ask me, well, what's the difference and why would I do one over the other? The plus is more comprehensive. It does require more collection, but you will get more data points. And it depends if the cortisol awakening response, if many of their symptoms start out with, well, in the morning I can't wake up. In the morning I feel worse. In the morning I have bad depression. In the morning my joints feel terrible. In the morning I get migraines. In the morning my anxiety is through the roof. Really helpful when we're looking at the cortisol awakening response. So specifically honing in on that, when people say, well, why all the collection? Because the cortisol awakening response kicks in about the first 30 minutes of waking, you're going to collect a salivary sample on waking, 30 minutes later, and then 30 minutes after that, or 60 minutes after waking. So it's basically waking 30-30. And the reason for that is that we're looking for that quick up and then gradually starting to decline pattern of cortisol to determine how your body is responding. The 4th collection is around dinner and the 5th before bed. And of course, if they have insomnia, they will collect then as well. Why is the CAR so important? Why do we think that it's important for our men to look at the cortisol awakening response in addition to the rest of the markers on the Dutch test? Well, we know that the CAR directly influences, that is influenced by a number of health outcomes. It directly influences energy levels, stress response, and resiliency, which is so important right now. It is directly influenced by how much you're feeling stressed out. It influences your alertness. It influences blood sugar management, type 2 diabetes risk, metabolic syndrome, mood such as anxiety, panic, depression, and worry. autoimmune development and progression. You need a healthy, pointy cortisol awakening response to help reduce autoimmune formation out of the thymus gland. A healthy car also reduces inflammation. It helps with inflammation regulation for those men who wake up in pain, feeling inflamed, their joints hurt, right in the morning, headaches. The car can play a direct role. Infection regulation, how many people say they wake up feeling kind of flu-like, feeling kind of sick, kind of feeling, just like their immune system's doing something wrong or overreacting? It influences memory and recall and cancer outcomes. So you can see this is pretty significant, all directed by the cortisol awakening response. And then lastly, on both the Dutch Complete and the Dutch Plus, we do look at a number of organic acids and neurotransmitter metabolites. You will see the the B12, 2B6 markers, and glutathione metabolites, the dopamine, norepinephrine, and epinephrine metabolite. They are not direct representations of dopamine or norepinephrine and epinephrine, but they are the neurotransmitter metabolite. Melatonin, and then of course, 8-OHDG, the DNA damage marker. All of these relate back to hormones. All of these relate back to cortisol. All of these relate back to all the other markers on the Dutch test, which is why we include them for extra added information. So as we move into men, basically we're going to come through each hormone pattern on the Dutch test and explain how they relate to the men that come into your clinic. We focus so much on women and women's health. We do know that it's women who tend to go to the doctor, but now as more and more men are looking to become healthy, as more and more men are looking to appreciate and become part of integrative medicine, as more men are looking for a more personalized approach and realizing that the way they feel is not necessarily normal, even though it is common, we have to address that. And that's why we are really glad to offer this webinar. So Men's Health 101, let's review some basics. Where are androgens made in men? Because we talk about it so much in women, and men it's a little bit different. So men, your testosterone is made in the testicles. Greater than 95% of testosterone is made there. When we're looking at DHEA, 80% of your DHEA, no S. So DHEA without the S is the active form, right? When you add the S on, that's the sulfate that makes it inactive. So 80% of the active DHEA made in the adrenal glands, 20% made in the testicles. All of your sulfated form is made in the adrenal glands. If you take DHEA, the supplement, the S is then added on in the intestines or in the liver. So it's a little bit different. So your endogenous DHEA S is made in the adrenal glands, but if you supplement with DHEA, you don't supplement with the S form, you supplement with the DHEA form, and then the body puts an S on it in the intestines and the liver most commonly. So when we're looking at how it all plays out, we need the top hypothalamus to release GnRH. So gonadotropin releasing hormone then tells the pituitary to make FSH. FSH goes to the Sertoli cells and says, hey, make sperm. We need sperm to mature and go through their cycles. And it takes about, depending on research you read, it takes about 70-ish days to mature a sperm. So with women, we talk about the 3-month cycle to get her egg fully matured. Sperm, men of course make sperm every day, but to mature a sperm, it takes about 70-ish days. When you're looking for fertility health, the preconception is just important for men, because think about, what did he do 70 days ago? What did he do 71 days ago and beyond that, right? We have to clean up those sperms. So give it about 70-ish days. You go for 3 months, just make it match, and to really improve those sperm health. LH tell the Leydig cell to make testosterone. So FSH is sperm, LH is testosterone. Men begin their life with about 700 million Leydig cells, and unfortunately, they lose about 6 million of those cells through natural atresia yearly after his 20th birthday. So men are born with a lot of Leydig cells, but they do decline. And as we know, there are a lot of things that decline these much, much faster than just aging itself, which we'll talk about. Testosterone basics, not a lot of people realize this. So the forms of testosterone in the body. Now, when it comes to testosterone, we all talk about total, and we all talk about free, but when it comes to that total, when we're looking at bound, what's bound up, please remember that we talk about SHBG all the time, sex hormone binding globulin. 40%-ish, roughly, of testosterone is bound to SHBG. It's very tightly bound to that. So if you're newer to understanding this, SHBG is like a bus, right? It has a lot of seats on it, and testosterone, when it gets on the bus, when it gets on SHBG, it drives it around the system to where it needs to go. Now, unfortunately, the door to that bus is really tight. It does not like to unlock for much. And so it can be hard to get testosterone off that bus. The amount of testosterone that is free is very small, 1 to 2%. It is the free testosterone that's available. It's not on a bus of any kind, and it's able to bind to receptors and do the things. 60% of his testosterone is bound to albumin. It's weakly bound. The door is swinging. It's like a breeze could happen and the door would open and testosterone could fall off of albumin. It's pretty weakly bound. So when you hear the word free testosterone versus bioavailable testosterone, please be aware bioavailable testosterone is a little different. Bioavailable is where we add up the free plus the testosterone bound to albumin, because it's so weakly bound, it could just pop off easily, as opposed to SHBG, which is holding on to it really quite tight. So free is literally the free not bound to anything, whereas bioavailable is the combination of free plus what's bound to albumin. And you're going to read this in research papers. You're going to see this when it comes to testing. You're going to hear this in lectures where speakers talk about free testosterone or bioavailable testosterone. So please be aware there, of course, is a difference, but the albumin bound is not as strongly bound as the SHBG bound. On the Dutch test, we have a marker called epitestosterone. Why do we care about epitestosterone? Well, it's an epimer of testosterone, which is where it gets its name. It is a weak competitive antagonist to the androgen receptor. And most males have an endogenous production of epitestosterone to testosterone of roughly 1 to 1. I believe some of the big sports athletic boards allow it to go up to 1 to 4. The reason this is important is it does not increase with testosterone replacement. So with doping, prior to technology really advancing, they used to check epitestosterone and testosterone in athletes. And if his testosterone was quite a bit higher than his epitestosterone, they would know he was doping with something. And so it's a roughly 1 to 1, 1 to 2, but I believe like the Olympic board allows it to go up to 1 to 4, a 1 to 4 ratio. Where do we use it? Why do we care as practitioners using the Dutch test? Because if you're doing something to improve his testosterone, whether you're using a nutrient, an herb, hormone replacement therapy, and he says it's not working, you can compare his epitestosterone to his testosterone and see. For example, in this case, his testosterone actually is 21 and his epitestosterone is 38. So it's not quite 1 to 1, but that's relatively close. Now, let's say he goes on an herbal combination and he decides to do testosterone injections. You will see that testosterone shoot way up. Maybe it'll go up to 121. That epitestosterone will stay at 38. And now you can see, like, oh, look, there is a big difference. What I'm doing is helping move the meter on testosterone compared to epitestosterone. It is also really helpful when you're evaluating for what's known as the UGT mutation, UGT2B17 mutation. This is a glucuronidation mutation. And unfortunately, what it does when you have this mutation as a man, although women can have it as well, when you have this mutation as a man, it does affect the way that you clear out testosterone. It does not affect the way you make testosterone. So if you have this mutation, you will see a very, 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 very low level of testosterone. Sometimes, a lot of times it'll be in the single digits. Sometimes it'll be below 1. It'll be like 0.5. And he's not on any replacement. And so in that case, in this example, if his epitestosterone is 38, and as an example, if testosterone was 0.5, I would suspect this mutation. Now, this mutation is a glucuronidation issue. It tends to affect other things as well, like bilirubin. These men are often also told they have Gilbert's when it comes to their bilirubin. And so be aware. And so you can look up, if you do genomic testing, you can look up their UGT2B17 and see. It is commonly, more commonly in those men of Asian descent, but it doesn't have to be. My husband, who is 6'3" Caucasian, has this mutation. He has slightly elevated bilirubin as well. And so he has this mutation through and through. So just be aware of that. In this case, if you have this mutation, serum testosterone then is the way to go. If you do not have the mutation, then of course, Dutch testing is the way to go. So let's look at the Dutch test male results. So here is for Dutch Complete or Dutch Plus, this is our page 2. Or excuse me, no, it's not. It's our page 3. This is our page 3 for those of you who are familiar with the test. So if we take out the estrogen part, we'll come back to that later. We look at androgens. So we have our DHEAS. Please remember the S is the sulfated form. This is not active. And then we have testosterone. We at Dutch look at bioavailable. This is why I was clarifying bioavailable. So free is in serum. Bioavailable is the combination of albumin and then, of course, testosterone. We also look at the metabolites. We look at what's known as the 5-alpha reductase pathway, your androsterone or androsterone, your DHT, and your androstenediol, which is what DHT deactivates into. So and then at the upper right-hand corner, we do provide age-dependent ranges. We'd like to please make you aware that age range and optimal range are not always the same range, because as we know, testosterone has been steadily declining and age ranges are matching the current population as is, not necessarily taking into account that testosterone for a quote healthy man was higher 10 years ago, 15 years ago, 20 years ago. The ranges are matching the population. So I often will get asked, well, his testosterone's in range, but he has all the symptoms. Like, age range and optimal range are not always the same range. When it comes to hypogonadism, there's primary, secondary, and mixed. So with primary hypogonadism, the origin is in the testes. He has high LH and low testosterone. So basically, the brain is yelling at the testes like, hey, make testosterone, do something, do something, do something, and the testes are not responding. Secondary is when the brain is the problem. The pituitary is not talking to the testes at all. And so the LH is low often, or low end of normal, and he also has low testosterone. This is why it's really important when you have a man with low testosterone to check his LH. Then you can determine if it's testicular or if it's pituitary. However, he can have both. He can have a testicular issue and a hypothalamic pituitary issue. So he has low T, and his LH and FSH honestly can vary. So now you're going to have to do some symptom digging to also see. Where might we see this? Well, I'll be honest, sometimes we see this in like traumatic brain injury, and maybe he also has testicular issues, whether it's autoimmune, whether it's hypothyroidism, whether it's toxicant exposure, what have you. And so you will use your critical thinking skills to say, okay, he's had a traumatic brain injury, and on top of it, he has all these things. So it's quite possible your hypogonadism is due to a combination of what's happening in the brain, and the testes themselves are not functioning as well as they should. If you're visual, here you go. So secondary hypogonadism is up at the top. So the LH will likely be low or low normal, whereas primary hypogonadism is in the testicles. Therefore, the LH will be high because it's yelling at the testicles to do something, make testosterone, and it's not. So we've talked about TD, testosterone deficiency is on the rise. Is it a growing epidemic? I think so, absolutely. The average level of male hormone dropped by 1% a year, according to Thomas Travison from the New England Research Institute in Massachusetts. This trend does not appear to be related to age. What does it appear to be related to? Well, a lot of study on, lifestyle, a lot of study on environmental toxicants, a lot of study on other factors, weight, autoimmune, things like that. So causes of low testosterone in men, please, please, please do not be like those testosterone clinics that pop up. Run a serum testosterone and put them on testosterone injections, and don't bother to look at anything else. We definitely see a fair share of men who go on testosterone, run a Dutch test, and nobody has bothered to look at anything else involved. Now, I know you listening are, functional in your approach and wouldn't do that, but be aware that those clinics are out there, and I think they're really doing a disservice, and especially they're doing a disservice to young men, because as we know, testosterone replacement, testosterone supplementation, will also suppress sperm formation. So I have had a number of young men who have not yet had their families, or maybe they've only had one child and want to continue to have more children, and they're on testosterone replacement, and I have to inform them that unfortunately their testosterone replacement has made their sperm count 0. And so please be aware of that. Root causes of low testosterone, age is a cause. If we do know testosterone can decline with age, but diabetes, having elevated SHBG, hypothyroidism. Men are often blown off that men don't get thyroid problems, which is absolutely not true. Men can. Traumatic brain injury. Male patients in violent sports are definitely at risk, car accidents, things like that. Zinc deficiency, outright zinc deficiency will decrease testosterone. This is obviously often due to gut issues, malabsorption, regular alcohol or marijuana use, if he's had a removed testicle, environmental exposures, obesity, sleep or sleep deprivation. Testosterone is made most in sleep. Medications that are suppressive, such as opioids and anabolic steroids. And then if his aromatization is increased. So these are the most common root causes. There are less common causes, such as testicular infarction, space-occupying lesion in the pituitary or hypothalamus, infarction in the pituitary or hypothalamus, decreased blood flow to the glands, and radiation to the groin area, and any kind of chemo at large. So definitely get a pretty solid history on him when you dive in. We know testosterone deficiency is common, and it can literally happen at any age. I get really irritated when people tell me like, oh no, men, we don't need to look at men's testosterone until they hit about 50. Absolutely, young men can have testosterone deficiency as well. I mean, we see it in our practices, we see it on the street, we see it observing people in the airport back when we were allowed to be in the airport. We see it all the time. And just like women can have hormonal imbalances at any age, so can men. The diagnosis is not just a lab test, though. You, of course, have to assess the entire clinical picture. And regardless of age, please look for clinical associations and root causes. With low testosterone, there are comorbidities you have to be aware of. Obesity, insulin resistance, diabetes, metabolic syndrome, sleep apnea, and cardiovascular disease. And what's the number one killer of men and women? It's cardiovascular disease. Testosterone deficiency predicts development of diabetes, metabolic syndrome, osteoporosis, and more. So just because he has low testosterone, please don't blow him off to think, oh, it's fine. You seem to be doing okay. Make sure you're doing due diligence and looking into these other issues. Check his glucose and insulin, right? Check him for heart disease. Like really assess him, because low testosterone can be quite damaging in the long run. With treatment for low testosterone, it's address the cause 100%. So we're looking at exercise, lifting weights, HIIT training, lifestyle, sleep, diet, hydration, reducing environmental toxicants. It's all the things that we know. I do want to say that this webinar is only an hour. I fully realize to do men's health any justice, it's going to require much longer than an hour. We're going to just sort of hit the high points in an hour, but some of these slides are going to be more like summary slides, and that's the reason why. So this is one of them, right? Address the cause. Conventional therapy to increase testosterone. You have testosterone replacement therapy. You can do HCG, which acts like LH to improve testosterone production out of the testes. And then Clomid. Clomid, of course, is an estrogen modulator, and by having that effect on the brain, it increases LH and FSH, and subsequently you can improve sperm formation and testosterone production. Now, when you're treating low testosterone, please remember that all hormones, all sex hormones, all steroid hormones, start in the mitochondria. And if you've heard me lecture before, I say that cortisol starts and stops, or starts and ends in the mitochondria. When you make a hormone, the star protein binds to cholesterol and goes into the mitochondria. That's the very first step. The next step is pregnenolone. Regardless, that's how it goes. Star protein to cholesterol to pregnenolone. That happens in the mitochondria. Pregnenolone then shifts over to the smooth endoplasmic reticulum, and there you will see where you can make testosterone. And then in this example, it's showing that it can go on to estradiol. If you were making cortisol, though, of course, pregnenolone would become 11-deoxy, which would come back out into the mitochondria and become cortisol. So that's why I say cortisol starts and ends in the mitochondria. Testosterone starts in the mitochondria, ends in the endoplasmic reticulum. Regardless, the mitochondria are very important. So please evaluate the mitochondria. Look at supplements such as lipoic acid, vitamin C, selenium, B complex, your magnesium, your manganese, your copper, CoQ10, your glutathione support, your sulforaphane, and your PQQ. You also want to include things, removing environmental toxicants, improving weightlifting, like the things, getting sauna, right? Like those things that really help mitochondria. Doing cold plunges and cold showers. So support your mitochondria. Other support for testosterone, though: zinc, vitamin D, B complex, vitamins A, C, and E, and then selenium, just sort of general micronutrient support for testosterone production. There are some herbs. I have question marks in nutrients by 3 of them. So tribulus, Maca and boron, they get a lot of press, they get a lot of use by practitioners. As far as like human studies, that's why they have a question mark. I'm not saying that they don't work. I'm not saying that those of you listening are like, but I love boron, it works amazingly, or I love tribulus. Absolutely. I was trying to provide you guys with the human study to back it up, and that's where it's a little iffy. Like mice, sure. Human, hard to find. Whereas longjack, uricoma, fenugreek, mucuna, ashwagandha, and black seed do have some good studies behind them. And so I don't want to not include, the three at the top because they are so used in our profession and they could be really helpful. But these are the common natural treatments for low testosterone if you're not going the HRT route. So let's talk about androsterone and etiocalanolone. They are androgen metabolites. So on Dutch testing, we do look at those. They are the metabolites of testosterone and DHEA. They are broken down by 5-alpha and 5-beta reductase. These two metabolites are 1/7, roughly, the potency of testosterone. They can be converted into DHT, they can be converted into DHT directly bypassing androstenedione and testosterone via androstenediol. So there is a backdoor pathway to make DHT that doesn't have to go necessarily through the androsterone pathway. Both of them are weak neurosteroids. They do have positive effects on the GABA A receptors. I do have practitioners that will see them elevated on the Dutch test and they will not necessarily jump to do anything about it because they feel it is helping to reduce anxiety in their male patient. We just have to be aware when it then affects DHT. So let's talk about 5-alpha reductase in that regard. 5-alpha reductase is an enzyme. It is located in, of course, the reproductive tract, his gonads, skin, hair, and the nervous system. It converts testosterone into the much more potent DHT, dihydrotestosterone, and it converts androstenedione into androsterone and then into 5-alpha androstenediol. So many crazy words. How do you increase 5-alpha reductase? What might be happening that would increase that DHT? Well, genetically, they may be a 5-alpha person. Inflammation, insulin, and obesity will also increase 5-alpha reductase. So lifestyle is a big treatment here, right? Lifestyle is a big one. Side effects, we know, cystic acne, male pattern baldness, he's more angry and irritated, and maybe he's experiencing some prostate issues, all because of this 5-alpha reductase and DHT. What is DHT? It acts mainly in an intracrine and paracrine manner, right there locally, wherever it is, the hair follicle or in the prostate. We know DHT in the prostate is higher than what's in circulation. Please keep that in mind. DHT binds more strongly to the androgen receptor and is tougher to knock off than testosterone. Therefore, research says action is approximately 2 to 5 times stronger than testosterone. So if you get a Dutch test back and his DHT is quite elevated, just understand this. It's binding strongly, it's tough to knock off, and it's acting much stronger than testosterone. It is inactivated by 3-alpha HSD to the weak androgen 3-alpha androstenediol. And thankfully, DHT cannot aromatase into estrogen, but we know that DHEA, androstenedione, and testosterone can. So when we're looking at this, we're looking, when you're looking at Dutch reports for a male, you're looking down that right column, and we have testosterone into DHT and then inactivated to the weaker androstenediol. So treatment, obviously lifestyle, addresses inflammation from wherever it is, reduces insulin, reduces adiposity. There are the 5-alpha reductase inhibitor medications. The natural 5-alpha inhibitors include the following. So saw palmetto, stinging nettle root, pygeum, which is Pygeum africanum, EGCG from green tea, and reishi mushroom. I will often get told or asked, or people will say, well, I gave him 250 milligrams of stinging nettle root and it didn't change anything. We do find 5-alpha reductase tends to be strong. So when you're dosing, I tell people, look, if it's really serious for him, you're going to have to dose on the pretty high end. And a lot of people will mix. A lot of people, or a lot of supplement companies even, will have mixes of saw palmetto with stinging nettle root, right, with pygeum, and or with reishi mushroom, or there's combinations. Sometimes you'll see it'll have zinc and pumpkin seed in there as well for the prostate and for testosterone or what have you. So just be aware though that if you're erring on the side of caution and you've got yourself down in the low range and you're frustrated it's not working for him, that I think 5-alpha reductase is strong, and so you need a higher dose to get it to reduce itself, right? Because you're trying to compete with the 5-alpha medications, right? So get that dose up there, and if you're trying to compete with the medications. So let's look at estrogen in men. So let's switch enzymes and let's look at aromatase and let's look at estrogen detoxification. So here are the estrogens, right? So there are the testosterone androgens we just looked at. If we delete those and we just look at the estrogen portion, those of you who do a lot of the testing on women will notice that that looks exactly the same. It is exactly the same. Men go through detoxification just like women do. So you'll notice that some of my slides, you'll think, well, that applies to women. It applies to men. So we look at E1, E2, and E3. We look at phase 1 metabolism, the 2, the 4, and the 16. And of course, we look at the methylation through COMT. So we look at all of them. Phase 3 is, of course, through stool testing. So at Dutch, we do not do stool testing. You will have to add in stool testing if that's a concern for your man and you're looking to evaluate phase 3. Is estrogen bad in men? Is it evil? Should we get rid of it? Not necessarily. Estrogen receptors are located all over, in the brain, in the penis, in the testicles, and adipocytes. It modulates libido. Men need some estrogen. It helps, believe it or not. It can help with erectile dysfunction and spermatogenesis. Symptoms of low estrogen: depression, lack of focus, hot flashes, bone loss, it's a big one, loss of muscle mass, and sexual dysfunction, which all sounds like low testosterone, doesn't it? But it also sounds like symptoms of high estrogen minus the bone loss. So this is why testing is really important. This is why at Dutch we say to test, don't guess, because you may be thinking, oh my gosh, he sounds so high estrogen in his symptoms. Or maybe you're thinking, gosh, he sounds so low testosterone. I'm just going to give him testosterone replacement, or I'm going to just put him on, mucuna and ashwagandha and zinc. And really, that's not the issue. The issue may be more estrogen related. So as men age, prostate levels of estradiol gradually rise, and the levels of progesterone and testosterone decline. The decline in testosterone and progesterone levels is greater than the rise in estradiol. Estradiol and DHT are synergistic in creating prostate problems. So we look a lot at DHT. In fact, a lot of people only look at DHT, but it is important to look at estradiol as well for those of you who are doing prostate health. In this lecture, I don't go into prostate health only because we have an hour, and it's that would require much longer. But definitely, if for those of you who see men and work with prostate health issues, you're doing your research and looking into that. So let's move on to that estrogen enzyme, though, aromatase. So we talked about 5-alpha reductase, totally different enzyme. That enzyme deals with DHT. We're going to talk about aromatase, which is part of your CYP family, your CYP19A1. This is what converts your androgens into your estrogens. What upregulates aromatase? So excessive alcohol. This is why we talk about the beer belly, right? Zinc deficiency, insulin resistance, inflammation, prostaglandin E2, obesity, stress, high leptin, leptin resistance, aging, and gonadotropins. So all of these things can increase estrogen production. Here's an example of what over-aromatization looks like for men on the Dutch test. This is a man in his early 40s who's on weekly testosterone injections. He came to his practitioner and said, I'm having weight gain. Despite being on these injections, I have weight gain, poor erections, low libido, and I'm tired. So when we look at this, if you're new to Dutch, the Dutch dials are read like a gas gauge. I should have said this way in the beginning. The Dutch dials are read like a gas gauge. So in between the stars are the normal range. And then the dial with the arrow on the end tells you, where his result is. So he's at his testosterone is 230, and the arrow's in the red because it's quite elevated. Why is it elevated? Because he gets testosterone injections weekly. Then his testosterone has to go somewhere, and his aromatase is kicked in. And therefore, below that, you'll see his estrone is 17.7. His estradiol is 3.65. So he has a lot of aromatase. Now, is it possible that he has some of these root causes to upregulate his aromatase? Yes, absolutely. Is it also possible that he's on too much testosterone, or weekly, getting the injections weekly is too either too much or not the timing is wrong. Some people might prefer low doses twice a week. It depends on the practitioner and the patient. Yes, absolutely, because the testosterone has to go somewhere. And in this case, it is chosen to go through estrogen. So what are common aromatase inhibitors? So we have anastrozole or letrozole, right? And then the supplements are apigenin and other flavonoids, white button mushroom, which is known as agaricus, chrysin. I will say the caveat with chrysin that I hear from a lot of practitioners is that it is tough to absorb orally. My compounding pharmacists report back to me that topical chrysin, often if you're doing a topical testosterone, they'll mix it right in. And the dose needs to be on the higher side. I'll have compounding pharmacists tell me that they'll often dose like 75 or 80 to 100 milligrams of chrysin in their dose in their topical. But then I have some practitioners who like the oral chrysin. They do it orally. They find that it works for their male patient, and it's not a big deal. So I will just say that one caveat for chrysin: if you're doing oral chrysin and you're like, this isn't working, either switch to something else or try topical. Genistein, grapeseed extract, and red wine procyanidin dimers are all the supplements. So and yes, anastrozole and of course letrozole. You will see quite a bit for women when it comes especially to breast cancer, but men use it, especially when they're on testosterone replacement. A lot of practitioners will just go ahead and do the medication. But maybe he's not on testosterone medication replacement. Maybe he is on, you're trying to work with, nutrients and herbs, or maybe you just know the problem is aromatase and you're just trying to hone in on that, decreasing that aromatase activity. And so you're like, you know what, I'm just going to do some apigenin and white button mushrooms and then retest and let's see. So you have a lot of options depending on, whether you want to like sort of slowly move this or whether you want to whack this over the head or what he has going on when it comes to aromatase. And the same goes for, like I said, with 5-alpha. You can do the 5-alpha, medications, or you'll obviously there's the ones for like hair loss is the big one, and and when it comes to the natural version of that, again, like I said, I feel like you have to use high doses. With the aromatase inhibitors, it's kind of the same. Like when you're trying to compete against anastrozole is your comparison. Just if you tell a man, you can't tell a man like, oh yeah, just eat white button mushrooms, add it to your diet, put it in your omelet. That's not going to do it. I mean, it's helpful. Diet food is medicine, but he would have to eat a lot of white button mushrooms to get the effect to really reduce that aromatase. So that's why as a supplement, it will work. Now, does it address the cause? No. Is white button mushroom going to lower his insulin? Is it going to reduce his inflammation? No. You still have to go back and address the cause. So estrogen metabolism, how do you evaluate phase 1 estrogen metabolism? So if we look back at our dials, and for those of you who've been using the Dutch test, you'll notice these dials look a little bit different. We decided to give you a little preview of the Dutch report that's to come, so be on the lookout for that. We're actively working on this right now. So estrogen there at the top, E1 and E2, and then we have our phase 1, 2, and 3, or excuse me, phase 1, the 2, 4, and 16 of the phase 1 detoxification. So when we're looking at phase 1, this is in the liver, and this is primarily, and this is where we get into our cytochrome P450 enzymes, the 1A1, the 1B1, and the 3A4. So with men, they absolutely can go down the 2, they can go down the 4, and they can go down the 16. The same applies. With men, how do you evaluate phase 2? Same applies. We're looking to see that methoxy, and we are looking at that methylation activity. We're looking to see how his COMT is working. We're looking to evaluate his methionine cycle. Is he able to go from homocysteine around to methionine to make SAM to help COMT? So again, if you're new to this and you have no idea what I'm talking about, definitely check out the estrogen detoxification information on the DutchTest.com website because it applies to men. And if you're experienced with this, you will be nodding your head like, oh yeah, absolutely. We need COMT to get his estrogen in a hydroxy state to a methoxy state. Why is phase 2 so important? Why do I care about his COMT? I want those phase 1 metabolites because they're harmful reactive oxygen species to be water soluble. I want them deactivated so we can get them out of the body, because if they're not deactivated, what do? They just recirculate And now he has all the symptoms of estrogen dominance again. And then, as I said earlier, phase 3 is through the GI tract. So for those of you who are interested in looking at phase 3, you will have to choose a stool company that looks at the enzyme known as beta glucuronidase. You also want to evaluate for other inflammatory things, right? Parasites, candida, inflammatory markers, bile health, all of that is important. When I talk about estrogen detoxification in men, I talk about it as phase 1 into 2 into 2.5, which is commonly, it's gaining more traction as like the ability to get from inside the cell to out of the cell and into the bile. That's what's being known as 2.5. And then 3 is the excretion through the intestines. But you want to address it as phase 3, then 2.5, then 2, then 1. Why do you want to start with the intestines in men? Because you want to make sure that his elimination route is open. If you are just jumping all over his liver to clear out his estrogen, but he has constipation, then you're going to end up probably doing more harm than good. So make sure, talk to him about his gut health, talk to them about his, his bowel movements. Make sure that if you're doing testing, you're going to address whatever comes up. You're going to get his beta glucuronidase enzyme into the normal range, so that as you continue to work on his estrogen, he is able to properly eliminate it. That's what we're going for. So don't just put all men on DIM. Many of you are probably thinking, well, isn't that what I give women? It is, but it's 100% what you give men as well. Same for indole 3-carbinol, I3C. They are specific for phase 1 detoxification. DIM and I3C are specific for phase 1. They mainly upregulate CYP1A1. That's why we like them. But your phase 2 and phase 3 have to be open first. And we start with phase 3 and then we work backwards, because it just makes logical sense. Oh, right, open up the elimination pathways and then move up from there. So phase 2 requires COMT and methyl donors. So now we're looking at magnesium and SAMe. Magnesium and SAMe are the top 2 when it comes to COMT. Then we can look at things like trimethylglycine, which is betaine. We can look at methionine. You can look at choline, methylated B vitamins, zinc. Basically, what you can do is look at a methionine cycle online on images and look at all those coenzymes and see where he may be getting tripped up. You can also do SNP testing. You can evaluate his COMT. You can evaluate his, every marker, every SNP that's involved in getting the methionine cycle to go round and round, because the end result is SAM. And SAM and magnesium are the big cofactors for COMT. So that's ultimately what you're trying to get for him. What slows down his COMT, what would block or, affect his estrogen detoxification? Well, if he has the mutation, if he is already estrogen dominant, if he has gut infections, certain foods, high levels of a thing called SAW. So when SAM is the donor, as it donates its methyl group, it then converts into SAW, SAH. So SAM donates its group, becomes SAH. SAH, too much of it, can block COMT. Again, we're just trying to get that cycle, that graph, to go round and round. Environmental exposure, bisphenol and PCB exposure. If he's on an SSRI or SNRI, that can affect the way his COMT works. If he's on a COMT inhibitor, and really anything that affects, again, that methionine cycle. So when you're evaluating his estrogen, you want to make sure you evaluate these markers as well. Phase 3 is the estrobolome, the estrogen microbiome. So you're going to address his bile health, address his gut microbiome, do some testing. You're going to increase his fruit, vegetable, or just fiber overall, especially if he's not having regular bowel movements. Work to avoid the standard Western diet. Be selective with antibiotic use. I'm not saying no antibiotics. I'm just saying maybe not an antibiotic for everything. Reduce or eliminate alcohol, especially with men when they're struggling with estrogen. I will say to him, look, I know maybe alcohol is a big part of your social scene, but it is also 100% affecting your estrogen, which is affecting everything else and causing a lot of your symptoms. Right now, we need to reduce or eliminate alcohol. And as I've said multiple times before on other lectures, but I will say it here again, I will often get pushback or arguments with the type of alcohol that he is drinking. So I will get the pushback of, well, I'm just drinking tequila on ice because that doesn't affect my blood sugar as much. And I'm like, that's great. You're right. It's still alcohol and you still have to detoxify it. And it's still going through your liver and you still have estrogen problems. Or he will say to me, well, I belong to a club where I get biodynamic, low glyphosate, low sugar wine sent to me every month. Like, that's great. Absolutely. Wonderful. Still alcohol, still have to detoxify it, still affecting your estrogen. So when he starts pushing back to you with excuses as to the alcohol that he drinks is healthier, but he's struggling with estrogen and liver clearance stuff, just keep that in mind. Avoiding and minimizing toxicants. Men also need to read labels. Men also need to be aware of what they put in their body, on their body, use in their home, what they do with their hobbies, in their yard. As a whole family, they have to evaluate this. Have him consuming prebiotics and resistant starches. Consider probiotics. And then on testing, if you see that his beta glucuronidase is elevated, consider calcium deglucarate supplementation. Now, calcium deglucarate does not necessarily lower that enzyme, beta glucuronidase, but what it does do, it blocks its action. You as the practitioner still need to work with him to clean up his gut. You still have to work on the cause, but it is a calcium deglucarate is a great Band-Aid that can work in the meantime to help him get symptom improvement. So let's look at the HPA axis as our final part of men's health. So men and sleep. This is really, really important. When should you test a man's testosterone? So this is, you can see time of day at the bottom, you know, midnight, 3 in the morning, 6 in the morning, 9 in the morning, at noon, what have you. So there's the big red bar. And that's in this case, in this study where they were looking at men and sleep and testosterone, when testosterone peaks. So when you're doing testosterone testing, please make sure if let's say you're not doing Dutch testing, let's say you're going to have a serum drawn, please make sure you do it in the morning. You're trying to assess for his peak testosterone rise. If a man comes to you and says, well, my testosterone's low, my practitioner, you know, sent me to the lab at my appointment on Tuesday at 4 in the afternoon, it might be low, but you want to assess, like, well, what's his ability in the morning, right? What's his ability? What's the ability of his LH and his testicle communication in the morning? So make sure he's going then. When it comes to sleep, it is made during the night, therefore sleep is very, very important in men. There's a small study that shows that daytime testosterone levels were decreased by 10 to 15% of young men who underwent just 1 week of sleeping only 5 hours a night. How many men do you know sleep only 5 hours a night? Either they can't sleep, they stay up late, they're gamers, they're on their computer because they're entrepreneurs, they're watching Netflix, or maybe they get up really early. So maybe they go to bed at midnight, but they have to be up at 5 to get ready for work. This can absolutely, over time, decrease testosterone, and be aware of that. What about testosterone and stress? High levels of epinephrine is associated with lower levels of circulating testosterone. We are right now in quite a pandemic of high epinephrine, high cortisol across the globe. And so you're going to see probably the long-term sequelae of this is the men come into your office experiencing diabetic issues, metabolic syndrome issues, you know, weight gain, fatigue, erectile issues, and they're not going to know what's going on. Make sure you evaluate their stress. This quote, penile erection is regulated by 2 opposing systems. You have your noradrenergic, anti-erectile, and basically your nitronergic, which is your nitric oxide, right? Your pro-erectile. My really good friend, Dr. Ralph Esposito, says adrenaline is the killer of erections. He says it all the time, and it's because if you're fight or flight, right, if your epinephrine and norepinephrine are elevated, then you have a tough time increasing that nitric oxide in the penis to allow for an appropriate or proper or healthy erection. So please evaluate his stress. So let's look at the HPA axis and the Dutch test. So this is the Dutch plus, so this is looking at the cortisol awakening response. And so what we have is we have on the Dutch Plus, we have the total DHEA production, which is where we add up DHEAS, etiocalanolone, and androsterone. Then we have metabolized cortisol, which is the roughly the total amount of cortisol that's been made and metabolized through the liver in the day. We have the salivary cortisol total, which is, this is free. This is the free cortisol total, where we're looking at all the points in the waking, 30 minutes after waking, 30 minutes after that, around dinner, and before bed. In addition, we look at VMA, so that's vinyl mandylate or vinyl mandylic acid, depending on which organic acid company you like. It's the same thing, just the naming difference. But this is the norepinephrine epinephrine metabolite. This is not a direct indicator. This is not norepinephrine epinephrine itself. This is the metabolite. Remember, norepinephrine and epinephrine have to get broken down by COMT and MAO. So these, take that into account when you're looking at these results. We also evaluate melatonin because melatonin, obviously, with sleep onset is really important for men and testosterone. So the circadian rhythm, to improve testosterone production, we have to start with his sleep habits. So we want to avoid blue or white light 1 to 2 hours before bed. Consider wearing blue light blocking glasses. This is where we see with our entrepreneurs and with our dads, we will see that they will put the kids to bed, right? The family goes to bed, the kids go to bed, and then the parents are like, oh, thankfully we now have a couple hours to ourselves. Let's either get the stuff done we need to get done, or let's get on our computer and answer stuff that we need to, or let's check mail, or let's watch that show on Netflix about serial murders. And then they can't understand why their testosterone's low and they don't sleep that well. So please educate them about that. Avoiding alcohol and sugar before bed, avoiding caffeine intake in the afternoon and evening. Be aware of stimulatory exercise in the evening before bed. For some men, this can really, really affect their sleep. I know men will ask me, well, I like to exercise somewhere between like 4 p.m. and 6 p.m. Fantastic. Just ask them about their sleep and keep an eye on their testosterone. And if it doesn't affect them, great, then they don't need to avoid it, you know. But if they say, well, I exercise after work between 6 and 7 or 6 and 8, and then I feel all hyped up, and then I can't wind down, and then I can't sleep very well, maybe exercising between 6 and 8 p.m. is not ideal for him when you're trying to improve his testosterone. Make sure he works on winding down 1 to 2 hours before bed, not winding up by getting on his computer and trying to accomplish all the things he didn't get accomplished through the day. Sleeping in a cool room temperature. Consider a sleep study. Does your man snore? Does he have sleep apnea, right? Does he breathe out of his mouth? Disordered breathing. He's not a nose breather. All of these things greatly affect how our brain functions. Why? Because it affects how oxygen gets into the brain. And let me just assure you that a lack of oxygen to the brain is bad, period. It's just bad. So if he is not getting proper oxygen up to his brain because he is a mouth breather, he snores, he has sleep apnea, it's going to affect literally everything through the rest of his body. We are talking about testosterone and men's health and things like that, but it will affect literally everything else. Also affect or evaluate other factors affecting his sleep. Do the dogs sleep in bed with him and wake him up? Does his partner snore, have sleep apnea, keeps him awake, restless leg? Does he co-sleep with his children? And the children are constantly like all over the place, like children tend to be. Is he sensitive to noises? Are they around something that has a lot of noise? The neighbors are noisy. The neighbor dog is barking all the time. Is there mold in the bedroom? So he definitely has to keep an eye on this when he's trying to improve his testosterone. What do we do for an elevated PM response when his cortisol, his epinephrine, his norepinephrine is high? Well, in the day, looking at the basics, so quality multivitamin, B vitamins, vitamin C. Remember, humans don't make their own vitamin C. Magnesium, essential fatty acid, and adaptogens. So focus on his day, quality in the day, to help with what's happening at night. But then at night, he can consider things like GABA support, so GABA itself, or maybe even pregnenolone, both of which can support GABA. And I know that there's information that GABA should not be, it's too big of a molecule, it should not be able to cross the blood-brain barrier. And if it does, if you take GABA and you feel better, then you probably have a leaky blood-brain barrier. However, there is some research to show that actually when you take GABA as a supplement, that your enteric nervous system talks to your central nervous system through what? through the vagus nerve, and the vagus nerve says to the brain, hey, make GABA, because there's GABA in the intestines, in the stomach, and we need to make more GABA. And so I thought that was really pretty cool, that it's possible maybe that the supplement tells the central nervous system to increase GABA production. Calming amino acids, L-theanine. Love L-theanine, one of my favorites. 5-HTP, please be careful if they're on antidepressant medication. Same for tryptophan. Not quite an amino acid, which is why it's in parentheses, but common is L-taurine, which is calming to the CNS and helpful for potassium, sodium, magnesium, calcium in and out of cells. If you're going to give 5-HTP or tryptophan, please, or even tyrosine for that matter, even though this tyrosine is not calming, please be aware that you don't want to deplete each other. They do have a rate limiting step there that converts 5-HTP into serotonin or L-dopa into dopamine. And if you front load the substrate, so if you're giving 300 milligrams of 5-HTP, you are going to down regulate the dopa to dopamine production. So you're going to upregulate serotonin and downregulate dopamine because of this rate limiting step. So just be aware of that. He may need 5-HTP for a while, but then you may either need to take him off or add in tyrosine or L-dopa to continue to maintain balance there. Calming herbs that are helpful at night, we look at magnolia, we look at ziziphus, we look at skullcap. These specifically inhibit the enzyme that activate cortisol. So when cortisol is in its active form, we just call it cortisol. When it's inactive, we call it cortisone. They go back and forth with this enzyme, 11-beta-HSD. The one version activates into cortisol. So these herbs work to slow that down. So especially at night when he's an entrepreneur and he's, or like doing all the things, he's gaming with his buddies and his cortisol is all jacked up, these herbs can help keep him more as cortisone, so to calm him. Other calming things, obviously chamomile, holy basil, which is also known as tulsi, avena or milky oat, passion flower, maca, and hemp-derived CBD. So in summary, testosterone is made during the night at the stimulation from LH pulses. So therefore, you're going to do whatever it takes to protect his sleep, right? That's like right out the gate. There are many causes of low testosterone. Please don't just blindly give testosterone replacement therapy. You can in the interim if you're trying to work on the cause, but also be aware testosterone replacement therapy can reduce his spermatogenesis. It'll reduce his sperm formation. So keep his age and his ability to have children, if that's important to him, in mind. But you always want to address the cause of low T. If his testosterone is low because of hypothyroidism, then address that. Don't just give him testosterone. Remember, inflammation and insulin can increase both 5-alpha reductase and aromatase. So go for those lifestyle first, and then just know that the supplements and even the medications are a great Band-Aid. An increased stress response can have a largely suppressive effect on testosterone production and, of course, on erectile quality. And then the Dutch test offers a comprehensive view for men's health. And I hope that in this hour-long webinar, as we broke apart each section for men, that you have a much better understanding of what they all mean and then what you can do as practitioners to help. So if you need more resources, please ensure that you have an account. Definitely, if you're new to Dutch, don't have an account yet, contact customer service. We do have a special offer for you. You can receive 50% off of up to 5 test kits when you sign up. So you can try them on yourself. You can try them on if your partner, you can try them on your clinic, your family. So you can get up to 5 kits at 50% off. And that concludes our talk. So thank you so much for listening. If you are not, please follow us on social media. We are on Facebook, Twitter, LinkedIn, Instagram, and YouTube. We definitely provide a lot of education. We have a huge educational goals. We've always had them, and we have even bigger ones coming up. And we're here to help you learn all about hormones through Dutch testing. So thank you so much.
Thanks, Dr. Jones. So we've got some great questions here that I'm going to throw at you.
Okay.
Does supplemental bioidentical DHEA increase DHEAS and total DHEA on the Dutch test?
Yes, it does.
Okay.
Yep. So if you're
Oh,
concerned, if you want, I don't mean to interrupt you, Amy. If you want
no, that's fine.
a baseline, you will have to stop your DHEA prior to testing. If you want to know if your DHEA is working, then you'll follow the instructions and you just stay on your DHEA. But yes, it will increase it.
Okay, so on the Dutch test, is the 80HDG an average of the values collected from the 4 dried urine samples, or is it a single data point?
It is a single data point. It's taken off all of our organic acids are taken off of the morning point. The other hormones are a weighted average. So like estrogen and progesterone and DHEA and even testosterone it's a weighted average of the 4 in the day, whereas the organic acids are taken off a single point.
Which nutrients or herbal supplements would you recommend to help increase DHEA in men and women over 50 years old?
That is such a good question. So because it's primarily made in the adrenals, anything you can do to support the HPA axis is going to help DHEA. However, if you're just trying to increase DHEA, if you can prescribe it, or you live in the United States, then giving DHEA replacement therapy is an option as well. I know DHEA is not over the counter in pretty much every other country except for the United States, and then it can be challenging. So what I tell those practitioners is it's adrenal support. It's adrenal support all the way. Whatever you do, whether it's glandulars, whether it's adaptogens, whether it's the B vitamins and the C and what have you, or all the above. That's what we know to do right now.
Okay. How does, and if I mangle these words, I hope I don't, how does off-label Aromatase and anastrozole use impact natural pathways? I have a patient on this by another practitioner, and I've been concerned about this approach to his low T.
So letrozole, very close. Aromatase, Arimidex and letrozole are aromatase inhibitors. So they inhibit the formation of estrogen in hopes of keeping it back at the androgens. It's to keep it in favor of the androgens. So on Dutch testing, what we will tend to see, we'll see it go 2 ways, is that we can see in men, we tend to see the estrogens be very, very low, because men don't make a lot of estrogen compared to women, and so they will have like the Arimidex will work, and then they will have really, really low levels. And then of course, in some men, if they're on a low dose, and if he has, as a man has a lot, maybe he's really overweight, really inflamed, uncontrolled diabetes, and we've seen this too, that even the medication doesn't work. So they're on Arimidex or letrozole, and their estrogen's still high anyhow, because the medication's like, I can only do so much. But if it's sort of the standard man, they're trying to reduce estrogen, we will generally see the estrogens drop really low. Now, what's the concern? The concern is it's too low. The concern is bone loss, right? Osteoporosis. The concern is mood, like depression. The concern is still having erectile dysfunction, because you actually, as men, need estrogen. And so we do see it on the Dutch test, and it can absolutely be too low and be a concern.
Do you add tyramine in the morning, or does it matter if it is taken with 5-HTP and tryptophan?
Oh, tyrosine. Yes, I do tyrosine. If I'm going to do tyrosine, I tend to do it earlier in the day. So some people will break it up. They'll do it in the morning, and then they'll do it like at lunch, and other people just do it in the morning. I do find tyrosine to be quite stimulatory because it is all about dopamine. And so if you take it too late in the day, you could have sleep issues. So you'll find a lot of supplements out there now that have both. You'll see 5-HTP plus tyrosine, or 5-HTP plus, mucuna, which has dopamine, L-dopa in it, or 5-HTP and L-dopa. So you will see combinations now. But yes, earlier in the day for tyrosine I think is better.
Can you suggest ways to increase 5-A-DHT?
To increase it? That is such a great question. Well, the bad things increase it, so inflammation and insulin. But to naturally increase it, unfortunately, I don't know. I don't know what I don't. We look into that as our clinical team, the researcher on our clinical team will look into that from time to time to see, because we do get requests of men who are very 5 beta, and they want more of they feel like that if they had more 5 alpha, it would help with like muscle mass and emotion and mood and just how they feel. And that's really tough, and it's tough to control. It's as well, because what I don't know is if we find the thing, whatever herb it is, herb X, you'd have to keep a really tight eye on that DHT to make sure that you're not obviously becoming now excessive in that direction. But I don't have an answer for you. I apologize.
Okay. What would you suggest therapy-wise for low cortisol in combination with low testosterone and elevated estrogen levels?
Oh, that's a really good question. So low cortisol. So low cortisol at one point was probably high cortisol, right? And so there's a feedback loop from at the hypothalamus and the pituitary. So high cortisol over time becomes low cortisol. So that you're just doing all your typical stress response things that you do, like how you manage stress with this patient, how you reduce stress, and then the nutrients, the androgens, the brain health, right? You're looking at things like bacopa, and you're looking at fish oil, and you're looking at ginkgo, and you're looking at huperzine, and like all that, cordyceps and maca, all the brain support. And then, don't forget about mitochondria. You want healthy mitochondria, because the mitochondria is where the testosterone and the cortisol is made. Mitochondria starts and ends in the mitochondria, or excuse me, cortisol starts and ends in the mitochondria, testosterone starts there. Now, when it comes to high estrogen, though, so low testosterone, high estrogen, you'll go back to the slides, and it may be an aromatase issue. It may be an estrogen detoxification issue. And what's great about Dutch testing is if his estrogen is high, but it appears his detox pathways are functioning really pretty well, then you may want to then look at phase 3. So that's gut testing. Or you're like, all right, his detox looks good. It's probably aromatase. So you can kind of rule out based on that. On the flip side, if his estrogen is high and you run a Dutch test and you see his phase 1 or phase 2 is slow, it's sluggish to drain, then you're going to address that and see if maybe his estrogen's high because of what's going on with his liver. Now, at the same time, you're evaluating why. Is it alcohol? Is it medications he's on? Is it lifestyle stuff? Is he a hobbyist that fixes cars for a living? So he's always surrounded by chemicals and things like that. So you're really going to dig into what's going on for all those pieces of the puzzle.
Okay, and I've got one last question. What might be some clinical situations for extremely high SHBG, and how might you address it?
So really high SHBG, it's interesting when men who have, we see this, men who are on testosterone replacement therapy, some men will develop really high SHBG because they get this huge influx, especially maybe like an injection, They'll get a big influx of testosterone, and the body has to put it somewhere, has to do something. And so as a responding part, SHBG goes way up to handle the fact that testosterone just came in at this huge bolus. High estrogen. Now with women, it's commonly with like the birth control pill or on oral estrogen, SHBG goes up. I will also sometimes see it for men as well. Men who have higher levels of estradiol, their SHBG will go up as well. And because SHBG preferentially binds, of course, the androgens. And so if he's even DHEA, although DHEA doesn't really bind to SHBG, now that I say that, usually it's more testosterone supplementation that we'll see really, that it'll, drive his SHBG up. Now, what to do about it? That is the $1 million question. If I knew how to lower SHBG, I promise I would just tell you. I have had more practitioners, I've had more bodybuilders, I've had more, athletes reach out to me and go, what do I do to lower SHBG? Like, how can I naturally get it to go down? Maybe they've gone off their injections, their testosterone injections, and they've been waiting over time. And there's very, 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 very weak anecdotal evidence about Avena, and there's very weak anecdotal evidence about stinging nettle root. So avena, which is milky oats, and stinging nettle roots. More often than not, though, when practitioners try it, they don't find that it works. It's not very helpful. But unfortunately, to get SHBG down once it's really high is really challenging across all practitioners.
Okay, that's it for today. Thank you everyone for joining us. And just remember, we will be sending the replay recording along with the slides tomorrow. It should receive about mid-morning to noon, lunchtime. Thanks so much, everyone. Have a great day.